Good morning, everybody, and thank you guys so much for taking part in my presentation. Today we will be talking about the role of nutrition in COVID-19, susceptibility and severity of the disease. And so one of the topics in my internship was to find a article related to nutrition and create a PowerPoint presentation, then of course provide the presentation to you guys all as well. So I do have the PowerPoint here in front, and then I also have some guidelines that you guys may have. And then here you go. You can just take one and pass them down. If you have any questions, you can raise your hand and I'll be happy to answer, or you can save them for the end of the presentation. So I chose this article because most recently what has happened to the entire world, well, we just got done having the COVID pandemic that affected everybody globally. And so I thought to myself, I started reading this article and I thought this is a great topic that we can discuss. And so these are the authors of this article that I'm going to be discussing with you. Publisher was Oxford University Press, and it was published for the American Society of Nutrition in 2021. Now, the objective, the main purpose of this article was to review the latest evidence that showed how malnutrition presented in all its forms, either overnutrition and undernutrition, can influence both the susceptibility and progression of COVID-19 in individuals. So what is susceptibility? So susceptibility is the state of being likely to be harmed by a particular thing, such as COVID-19. And for instance, just in general, how could we, formulate susceptibility in our normal daily lives? For instance, a lack of exercise could increase our susceptibility to disease. Now, the key issue here is that nutrients have immunomodulatory actions with the potential to alter susceptibility to disease, in this case COVID-19, the progression of symptoms, and the likelihood of severe disease and survival, actually. So basically, nutrients can either stimulate or suppress our immune system, which will either benefit us or can actually harm us as well. So the importance of knowing this type of information is, we now need to discover how COVID-19 positive individuals can benefit from nutrients, and how nutrition status can alter susceptibility and severity of disease once infected. How are we going to get better faster? Maybe how can we prevent us from even getting COVID-19, if that's even something that we can do. And then we also must understand the importance between our nutritional status and the risk of COVID-19, and therefore now we can create, once we know this importance and how it can affect COVID-19, now they and experts are able to generate evidence-based recommendations. Any questions so far? So previous data, research, and trials. So we all know this was a brand new pandemic. We had not experienced anything like this before, so no previous data exists related to nutrition components' role in COVID-19. There is no previous data that exists related to your nutritional status, role in susceptibility and severity of the disease. and no previous clinical trials existed in relation to nutrition and COVID-19. So there was really nothing I could go back and refer to, and so that was a little bit of a challenge. So the methods. So in this article, they used several methods. They used a systemic review of nutrient and nutritional condition in related to infections. So this was kind of a similar, right? We were infected by a virus with COVID, so the most closest thing we could go back and maybe research was how nutrition's role plays in infection. And then there was a systemic search of literature, any type of literature that might have been available in either PubMed and Embase. And then there are also 6 clinical trials that were part of this article that I am presenting to you today. So nutrition-related components reviewed. So several nutrition-related components that were part of this systemic review are the overweight status of a patient, obesity, diabetes, protein energy malnutrition, anemia, vitamins A, C, D, and E, polyunsaturated fatty acids, iron, selenium, zinc, antioxidants, and nutritional support. So all of these components were reviewed in this article, and how it will play a role in susceptibility and severity of COVID-19. And so just a little bit of a background on the coronavirus, also known as COVID-19. It is caused by the SARS-CoV-2 virus. So symptoms can range from mild, moderate to severe respiratory illness, fever, cough, fatigue, loss of taste, smell, headaches. And then prevention was vaccination, social distancing, face mask, hand washing, covering your mouth and nose when sneezing, and of course the ultimate, staying home when you're sick. So that's kind of what we all did. The world shut down. Most of us in healthcare weren't able to shut down. We continued to work, and here we are now. So nutrition's role in COVID-19. COVID-19, of course, primarily affects the respiratory tract. But patients can also have GI symptoms such as diarrhea, nausea, vomiting, loss of taste and smell. And then it can also present, patients can also end up with protein energy malnutrition, which is the cause of the highest mortality in both the elderly and patients who had protein energy malnutrition prior to becoming infected with COVID. This is just a screenshot of all the medical terminology that was used. So, for instance, CRP stands for C-reactive protein, EN is enteral nutrition, PN, parenteral nutrition. And so what were the results? What were the results of these trials and research studies? So they've determined that obesity has poor COVID-19 outcomes found in all studies reviewed and conducted. There's a higher risk of severity of disease for patients that are obese, increased risk of ICU admission or death, and patients that were obese required more invasive mechanical ventilation. Patients with diabetes is a common, while it is a common comorbidity among the COVID-19 patients, it did increase incidence of ketosis and ketoacidosis and developed more complications and even death. And anemia was associated with longer hospital stays, but not necessarily associated with increased mortality. Vitamin A has an established role in supporting immune function and protecting against viral infections like COVID-19. There was little evidence found to support a beneficial effect on respiratory infections. Vitamin C does support immune function by promoting cell migration to infection sites and participates in macrophage microbial killing, but the evidence was weak to determine efficacy in studies and trials so far. Vitamin D supports immune health. Binding sites for SARS and COVID-2 is ACE2. So vitamin D balances ACE2, providing a mechanism for potential role in prevention and progression of COVID-19. So vitamin D did have some positive results. Vitamin E's main role is an antioxidant. There was no benefit found in reducing incidence, and some evidence that vitamin E made infections more serious. And then we also have polyunsaturated fatty acids. Omega-3s do have anti-inflammatory properties and significant benefits for outcomes in the ICU or mortality. The needs were tailored for each patient, of course, and some studies suggested addition of aspirin to the regimen as well. Selenium also has an antioxidant role found in staple cereals. Some studies yielded better results and improvement in short-term mortality. Zinc also has immune functions, sometimes used to treat the common cold, which is also a virus, just like COVID-19. Did promote faster recovery time, but more research is needed. And then COVID-19 nutritional support. So what were we doing for patients in COVID-19? There was a feeding protocol, which early nutritional supplementation, early screening for risk of malnutrition. All patients should be started on whey proteins, multivitamins, multiminerals, and trace elements. Patients with greater nutritional risk were started on an oral nutritional supplement. Parenteral nutrition if unable to tolerate oral intake. It was estimated about 30 kcal per kilogram to meet daily estimated needs. 1 gram of protein per kilogram per day was almost a standard, unless there was contraindications for that as well. And that is basically the end of my presentation. Does anybody have any